By the way, we are live now.
Okay.
You can start the meeting.
Okay.
মই মোৰ স্ক্ৰীনখন মিনিমাইজ হৈ গ'ল যে মই ক'ৰ পৰা ওলাম
তুমি ওলাই দিয়া তাৰ পৰা
স্ক্ৰীনত কিবা কিবি বহুত আহিছে দেখোন
No, what you can do is share the entire screen.
yes
You just you share the
Okay, you
entire
can
screen open the PowerPoint again. You just
Entire
stop
screen?
sharing.
share
মই স্ক্ৰীনৰ আইকন বিলাক আহিছে চব
So you can open the WhatsApp. Okay,
No.
open the what's called
No,
PowerPoint.
am I visible now or not?
Okay. Yes, you are visible and audible.
Okay.
So,
You
So
can
you are sharing screen.
okay.
no
Should I stop sharing?
yeah, you share the entire screen.
Share.
Entire screen. The left top, you share the
Yeah.
entire screen.
Just a minute. Share the entire screen, yes.
Then open your presentation. Open your presentation.
Can you see it now?
Yes.
Yeah.
Make slides.
Okay.
Okay, you can see it now. Okay, ma'am, start. You can start.
Yeah. So, good evening and welcome to Neboy Classroom. We are very happy that our all-time treasurer of AOI, Dr. Jogesh Davolkar, is with us as an expert faculty. And we have speaker with us today, Anjan Jyoti Bhuya, and a moderator, Dr. Manish Singh. So I am giving a brief biodata and brief CV of all of them. So first we start with Dr. Jogesh Davolkar. He is presently the professor and head of the Department of ENT at Dr. D.Y. Patil Medical College, Nerol, Navi Mumbai, with over 24 years of undergraduate and 20 years of postgraduate teaching experience. He specialized in endoscopic ear surgery and endoscopic sinus surgery. He is PhD in otology and authorized several index publications. He was invited faculty EAONO Copenhagen 2018 and Asia Oceania Hyderabad 2019. Then he is faculty for AOICON 2020 to 25. He is chairman of editorial board IJOHNS AOI and ex-honorary treasurer of AOI 2018 to 2025, past president of AOI Mumbai branch. We welcome Dr. Jogesh Davolkar as an expert faculty. Next, I am introducing today's speaker, Dr. Anjan Jyoti Bhuya. He is a senior consultant at PA Sangma International Medical College, Dispur Polyclinic and Hospital, Northeast India, ENT Institute. Then his area of interest is otology and rhinology and also neuro-otology. He was invited as guest faculty in various regional and national workshops and CME and of course conferences. Today in Neboy Classroom, he is going to speak on adenotonsillectomy, indications and newer surgical techniques. With us also Dr. Manish Kumar Singh. He is a moderator of this session. He is a graduate from Assam Medical College, Dibrugarh, and PG diploma from Guwahati Medical College. He trained in endoscopic sinus surgery at Trichy under Dr. T. N. Jankiram. His area of interest is sinus and skull-base surgery and obstructive sleep apnea. This is a small brief CV of all the faculties here. Now I welcome and invite Dr. Anjan Jyoti Bhuya to make his presentation. Over to Dr. Anjan.
Good evening all. Good evening, Khanna ma'am. Thank you very much for your this introduction. And today, actually, I was supposed to talk about the tonsils and adenoid, but the thing is that tonsilous adenoid is very known to all of us since our first day of our ENT practice. So we all know about tonsils and adenoid. Maybe all are expert on tonsil and adenoid. But the thing is that there are a few points where we need to discuss it again and again. So there are very little talk going are happening in about tonsils and adenoid. So let me discuss something. Very few basic points here. So, okay. So, little bit of anatomy of the tonsils and adenoid. So, adenoid, we all know, is the it exists as a pyramidal or rectangular mass of lymphoid tissue in the nasopharynx. So, it may extend from prosa-rosenmuller to eustachian tube. So, histologically, it has got four lobes. The first line of defense of inhaled pathogen. So what happens? The antigen is capture cells in the surface of the adenoid. It affects the antigen that stimulate the beta cell, B cell, and stimulate the germinal center to produce IgA and inhale the immunity. So it acts as a bacterial reservoir also in sometimes, and the bacteria can develop biofilms over the adenoid tissues. So about the blood supply and all, uh, it gets supplied from internal and external both carotid arteries, and from the superior part, this is the basis sphenoid artery. The basis sphenoid artery is exactly it's a branch of from the inferior hypophyseal artery, that is a direct branch from the cavernous part of the internal carotid artery. So basis sphenoid artery actually that supplies the basis sphenoid bone, and it pierces the periosteum and supplies the upper half of the adenoid tissues. So there is some importance of this artery because this artery is not covered by any muscular muscle. So if there is any open vessels in that area, so there may be some bleeding later on. So this artery, if there is some bleeding at the upper part of the during surgery time, upper part of the adenodectomy, then we need to cauterize it. Otherwise, there may be bleeding. We'll have to be more cautious in this part. So, ascending pharyngeal arteries is another branch. Pharyngeal branch of the maxillary artery is another branch. Tonsillar branch of the facial artery also supplies the adenoid, and artery of the pterygoid canal that supplies the adenoid. So, actually, the pterygoid canal we all know. Pterygoid canal artery is a artery that directly communicate the internal and external carotid artery. So it has got some importance in that way. So venous drain is into the pharyngeal plexus of veins, and the lymphatics into the pharyngomaxillary and the retropharyngeal lymph nodes. And nerve supply is not much important, but it is from the vagus and the glossopharyngeal nerve. So it presents at the 7 month of gestation and keep enlarging till 5 to 6 years of age, and maybe in some cases it may keep on enlarging up to the 10 years or so, and gradually it start decreasing its size, and after 14 years it usually disappears with a small remnant. But in some patient there is persistent adenoid tissue is found in, and that causes the symptoms. The person is it is persistent tissue is more common in immunodeficient patient, but it is not related that the immunodeficient patient, persistent adenoid means the patient is immunodeficient. It is not like that. But the immunodeficient patient have more commonly have the persistent adenoid. The reproliferation again may happen due to persistent infection of the adenoid. So sometimes in the in later period of use case, the if the adenoid is small size, then after the 20 years, 24 years, it may start grow or it may proliferate because of the persistent infections. So adenoid hypertrophy may be related to the impaired mucociliary clearance. It may is related to allergic rhinitis. You all know that, and smokes and indoor cigarette smoking is also responsible for childhood adrenal hypertrophy instance. So endoscopically, we grade the adenoid because of our confidence of reporting. Let's say grade 1 grade 2, grade 3, and grade 4. Grade 1 is the one third. If we use a 0-degree telescope and see the corner, if it is covering the one third of the vertical portion of the corner, it is grade 1. Grade 2 is the one third to two third part of the corner. Grade 3 is two third to nearly complete, and grade 4 is the complete obstruction. So adenoid hypertrophy is most likely associated with the apparent immune reaction. It may be associated with infections and environmental exposures, hormonal factors, and there are some genetic factors also there. So, adenoid causes airway obstruction can lead to obstructive sleep apnea syndromes, chronic sinusitis, otitis media with effusion. It formation of the malocclusion and developmental anomalies in craniofacial areas, speech disturbance and articulation errors, disorder in physical and intellectual development. So prevalence is estimated at about 1 to 5% of the pediatric population, with symptoms peaking between the 2 to 8 years of age. So there are a few pictures of the adenoid facies. We all know that the high arch palate, dental malocclusion, uh, flattened malar eminences, pinch mouth. So these are pictures of adenoid facies. So, what are the indications of adenoidectomy? Adenoidectomy without tonsillectomy, it is an often first surgical treatment options in children with chronic rhinosinusitis due to strong relationships of adenoiditis with chronic rhinosinusitis. So its effectiveness is about 60%, but in younger children, if it is less than 12 years of age in particular, it may be benefited from the procedure of adenoidectomy. So in a patient of CRS less than 12 years of age, so patient is helped by doing adenoidectomy. So adenoidectomy also helps to prevent the craniofacial disfigurement due to chronic mouth breathing. And studies also shows that neurocognitive functions in snoring and non-snoring children, it is shown that uh, with snoring, there is decreased level of concentration, memory, and learning ability and intelligence. So with adenoidectomy, if it is obstructing, so or is the silent snoring, that we can avoid those complications by adequately treating the adenoid. So adenoidectomy also should be considered in children with otitis media with fusion with associated nasal symptoms of airway obstruction. Children with persistent otitis media with effusion aged more than 4 years, and children of aged less than 2 years with recurrent otitis media should also be considered for adenoidectomy. So there are many treatment options like we may not need treatment in few cases. Intranasal corticosteroid, you all know we use Montelukast. Sometimes we give, it has got the property of reducing the size of the adenoid. So before doing other intervention, we give patients with Montelukast. Long course of antibiotic for the MRSA so can be helpful in some patients. And adenodectomy. So adenodectomy is the what is the process of adenodectomy? We do it can be done by curetage, debridement, coagulation, and sometimes combination of both. There is this is a comparison study of review articles of around 1494 articles reviewed. So they have found that there is no single technique that can be considered best for all possible outcome. So it can be considered that all the techniques, surgical techniques, are good with good hands. So all the techniques has got some advantages, some disadvantages, but with experience of the surgeon, if one surgeon stick to one uh, techniques and he expertise on that technique, then patient can get the best result out of it. So what we want to achieve actually of doing an adenodectomy is that we want to achieve the patent nasopharyngeal airway. We should not have left behind any infected adenoid tissue. There should not be any recurrence, no direct or indirect pressure on the eustachian tube. We don't want to injure the buccopharyngeal fossa and to avoid nasal resuscitation and no nasal intonation of voice. So these are the things we need to achieve after adenoid surgery. So curettage adenoid Lumpectomy, we all know it's a very quick procedure. Incomplete removal is very frequent, and it's a blind procedure, so little bit of bleeding and sometimes injury to the eustachian tube, thassa, or perimysium may happen. So these are few videos of debrider adenoidectomy. So if you can see with the debrider, it is possible to completely remove the adenoid tissues, where you can see that the remnant tissue in the fossa Rosenmuller has been removed by debrider. So with debrider, the radical adenoid surgery is possible, but little bit of more oozing or sometimes bleeding happen, but that can be controlled. So as you can see in the next picture, so the muscle layer is also quite exposed, and the in the upper part there is some coagulation is seen. So this coagulation is because of the that we need to avoid any bleeding from that area. So, but in the muscle in the inferior part, as there is muscles, so we need not have to do too much of coagulation. So, the other technique of adenectomy is the very frequently we do is the coblation technique. So, coblation is very popular for adenoid surgeries nowadays, and most of my surgeries I do is by coblation. So, it is an under saline water radiofrequency ablation. The tissue ablated by precise generation of the plasma field. So there is different one available. So there are some aggressive and there are some non-aggressive ones. So we can use whatever is comfortable for the surgeon. So this video is from a YouTube video, but this is my own video, so I have placed it here. So it's about the choice of the surgeon that what one you want to use, and in what setting you want to use the coagulation one. So if you can see the video, so how fast we want to dissolve the tissue. So it is usually advisable to use a non-aggressive one in the very early part of one's career, as we have more control over the one, we can go for a aggressive one. So choice of energy setting is another important point that what 7, 8, or 9 can be used, but it depends on how fast you want to dissolve the tissue. Near the vital structures, we use usually a little bit of lower energy. The fast dissolution of tissue prevent clogging of the one, because clogging of the tissue one is one of the major issues during surgery time, because if we need to remove the one repeatedly, then it gives a lot of trouble. So faster dissolution and the of the tissue can be prevented by giving a high energy setting. So high pressure water can be used sometimes to prevent clogging, and intermittent flushing of water that helps to prevent the fogging of the lens. So tissue contact time is important. Too fast movement of the one leads to less coagulation of the bleeding vessels, and there will be little more bleeding. Efficacy is less over the hard tissue, and high energy setting leads to decreased life of the one. So if we use high energy, the life is decreased. So what you can see, I have already removed most part of the adenoid, and what we can see is the perimysium. You can see the fossa over here. So so we can remove the tonsil as much as you want, adenoid as much as you want till the level of this fossa. So next, okay, let's come to tonsil now. So as you all know that tonsil is the aggregation of the lymphocyte arranged in the follicular manner embedded in a stroma of connective tissue covered by stratified squamous epithelium that invaginate to form the phallus. So adenoid is covered by the pseudo-stratified columnar epithelium, and the tonsils are covered by the stratified columnar epithelium. Being part of the older thing, they both provide the cell mediator, the humoral immunity. Due to the extensive background of the immune system, adenoidectomy and tonsillectomy does not cause any immune deficiencies. Little bit about anatomy of the tonsils. It is developed the 14th week of gestation. Tonsil and the tonsillar fossa develops from the ectoderm of the second pharyngeal fossa. Originally, two lobes divided by the intratonsillar cleft that forms the crypta magna. Superior and anterior part of the fossa is not filled by the tonsils, so small depression remains and is covered by mucosal fold that is called plica seminalis and plica triangularis. So plica seminalis is in the upper pole and the plica triangularis is the mucosal fold in the lower pole. So supratonsillar fossa separates the tonsil from the uvula. The plica intratriangularis is a frequent hiding site for the foreign body. So this is the plica triangularis, intratriangularis. So the foreign bodies or the small fish bones sometimes may hide in that area. So medial surface is, you all know, there are a lot of furrows or there are a lot of crypts. That the 10 to 13 crypts are there, and those are branched. So after ultimately the surface area of the tonsils become around 300 square centimeter. So the dendritic cell on the surface of the tonsils uptake the antigen and it transport the antigen to T cell and the B cell follicles and helps in immunity. So lateral surface is the most important surgical aspect of the tonsils. That the tonsil capsule is the lateral covering of the tonsils. Its upper part is condensed and is very loosely fixed. So, and the lower part is firm and it forms a suspensory ligament to attach to the tongue. Loose areolar tissue is also called lateral to the capsule is the loose areolar tissue space that also called the peritonsillar space. It contains the peritonsillar veins and this is also the space for peritonsillar abscess. So, lateral to that is the pharyngobasilar fossa that covers the first layer of the uh, constrictor muscle, superior constrictor muscles, and superior constrictor muscle in the upper part of the tonsillar fossa, and in the lower part of the tonsillar fossa is the sternopharyngeus muscles posteriorly, and stylohyoid and middle
ঠিক আছে মই চাই লম হা
glosopharyngeal nerve and the
ঠিক আছে
styloglossal
রাখছি
muscle are anterior inferiorly. So, little bit of surgical anatomy of the tonsil because of the close proximity to the parapharyngeal and the retropharyngeal masticator and aortic space that any inflammatory disease in the tonsils and or the peritonsillar space can be easily expanded to this the next spaces. The superiorly tonsil is free, but inferiorly it is attached to the suspensory ligament we already have discussed. The palatoglossus. Okay, so during the lateral pharyngoplasty, when you do the sleep surgeries, so relaxation of this muscle, the palatoglossus muscles or the anterior is important, and if doing a myotomy of the palatoglossus muscles, which antagonize the levator palatini, uh, it helps to keep the oropharynx open. So palatopharyngeus forms the posterior boundary. It has got two heads that arise from the palatine aponeurosis, and the levator palatini arises between the two heads of the palatoglossus. So it helps in the palatopharyngeal closure. Uh, in radical tonsillectomy, if you do, we need to understand about the distance of internal carotid artery, and which is at the tip of the epiglottis level, it is about 10 to 20 millimeter, and at the level of the eustachian tube, it is about 23 millimeter. So it is little more proximal to the tonsils in the lower part. So again, during removal of the adherent tonsillar capsules to the tonsillar bed, lingual branch of the glossopharyngeal nerve may be injured. So the injury to the glossopharyngeal nerve may cause post-operative pain, dysphagia, and sometimes there is phase disturbances. Little bit about the vascular supply. We have got the upper part, middle part, lower part, upper part descending palatine artery, and I'm not going to details about this. That the vein, peritonsillar vein, drains the pharyngeal venous plexus into the facial vein and the interjugular vein, lymphatics that into the upper deep cervical node, and nerves are the tonsillar branch of the glossopharyngeal and the lesser palatine branch of the pterygopalatine ganglion. So, tonsillectomy, there are different types of tonsillectomy. Whether it depends on whether we are going for a benign condition or malignant conditions. But nowadays, the intracapsular tonsillectomy is gaining its popularity in some Western countries. They are very common, mostly in the pediatrics age group. Intracapsular tonsils means we keep the tonsillar capsule intact. So it is possible with coblation. So extracapsular tonsillectomy is a very commonly done procedure. We all do it. We dissect it in the plan of peritonsillar space. Type 1 tonsillectomy, it's mostly done for the carcinoma in situ or for the diagnosis of the dysplasia and all. That should include the pharyngobasilar fascia and the anterior pillar. And if it is type 2, then we should include it's a buccopharyngeal fascia that includes the palatoclosus, palatopharyngeus, and the superior constrictor muscles. It is done for the invasive carcinoma, not closely included just constrictor muscles. Type 3 is a radical tonsillectomy. Include the buccopharyngeal fascia along with the pterygoid muscles and the parapharyngeal space adenoid adipose tissues. So nowadays, some radical tonsillectomy is happening, and the robotic surgeries or is happening. So in those cases, we need to remove the parapharyngeal space tissues. So a lot of surgical tools people has been experimenting for since long, and we are still looking forward which surgical tool is best. But till now, there is a lot of comparative studies have been published, but there is no evidence that one technique is much superior to the other. So all techniques has got its own merits and demerits, but the surgeon's experience is with these surgical tools is helpful for the patient. So we can use the steel, we can use the electrocautery, radiofrequency, laser, harmonic coagulation. Nowadays, the what I do mostly is the bipolar electrocoagulation technique. So what I do is I set the power at around 20 to 25, and in the bipolar mode, there is different mode like micro, precise, or macro. I use the micro and precise mode most commonly. Copious amount of water is there, and continuous suction and magnification helps. Magnification means what I do for me is I use a microscope. So this is a case of tonsillectomy. I use the bipolar uh, electrocautery for this. So I gave the incision on the anterior pillar. What you can see, the precise mode helps me to cut the tissue without emitting the uh, without generating too much heat to the surrounding tissue. But to minimize the heat, you need to put lot of irrigation, lot of water. And if you are using a microscope or other magnifying device, then your plan is you are not going to lose the plan. So whenever we are using a powered instrument, we need to use magnifying device, or otherwise we may end up leaving the tonsillar tissue behind in the fossa. So what you can see, I am just dissecting and coagulating the on the peritonsillar space, and yes. So at the same time, I am using a lot of irrigations, and here I am cutting the ligaments. So after surgery, what you can see is the okay. What you can see is a very nice tonsillectomy uh, fossa. So these are the pictures. These are the pictures of post tonsillectomy. This is after 5 days. This after 10-15 days. So what you can see is a patient is comfortable, and I have not seen any major differences in terms of the bleeding and all postoperative bleeding or the secondary hemorrhage with using this bipolar coagulation. So this boy is a case of okay. So this is a intracapsular tonsillectomy. What I use is a coblation. techniques. So intercapsular tonsillectomy is possible with coagulations, and patients has very minimal pain, and just after surgery he can take swallow without much pain, and the healing is also very fast. So this is a case of T1 lesions of the tonsils, and another yeah. So this is a tonsillectomy done for a case of sleep surgery. So with the help of coagulations and the other devices. So yes, this is the pictures after 1 month. Okay. So coagulation tonsillectomy is very helpful in pediatrics age group. So it can be used. The plan is very precisely we can use, and what you can see in this, I am using a non-aggressive one about in the coagulation power mode of 7. I started from the superior to the inferior pool, descending towards the. Whenever you use the one, yeah, the direction of your one should be towards the tonsil cap, so it's not towards the muscle layer. So with magnification, you can see precisely about the tonsillar space, and very without any bleeding and without any muscle injury, it's possible to remove the tonsils. Uh, so every time we use the coagulation device, as because there is less bleeding, the plan is very clear, and with magnification, the surgical planning, the patient gets a very good result. So okay, so this is the last part of the surgery. So what you can see is the tonsillar bed. This tonsillar bed is uh, what I want to stress here is though I am using the power device, there is no muscle injury, and I was able to remove the tonsils from the tonsillar bed without injuring the single muscles, and there is pharyngobasilar fossa. You can see the fossa. Yeah. So this tonsillar fossa is going to be healed very soon. Yes. Uh, Thank you very much. Thank you very much for your patient hearing. So there are a lot of uh, issues that need to be discussed, and I skipped a lot of things because of the time constraint. Uh, Thank you. Thanks for your patient hearing.
Over to Yogesh sir, your comment on this presentation and your input as well.
Yeah, very good presentation, and I liked how the entire, the anatomy, clinical anatomy was highlighted, and how each and important structure around the tonsil, what is importance of palatopharyngeus muscle, what is importance of palatoglossus muscle, all that was highlighted. So excellent presentation, and video quality was also very good. And I personally I use Poblator also, and I use Cold Steel also. And as this Dr. Anjan has said that there is no one technique superior, but there are merits and demerits of each and every technique. So always we have to keep that in mind while doing tonsillectomy. And though the tonsillectomy for the patient, many times they feel that it is a minor surgery, but it is not a minor surgery. And we have to always, exert the maximum attention to detail and seriousness to this surgery. As one great surgeon has said, there are no minor surgeries. There are only minor surgeons. So we have to be, particular attention to even each and every detail of tonsillectomy. As the speaker has mentioned, each and every part is important. And when we are respecting the anatomy, the post-operative results as well as the chances of complication they are brought down. With my experience of coagulation has that sometimes if we are not careful, particularly about the coagulation mode, then there may be a deeper tissue injury. So we have to take care of that. Otherwise, that comes as a post-operative bleeding sometimes after 12th day or 10th day. So that part we have to take into account. If we respect that and use the coagulation mode as less as possible, then usually this doesn't happen.
Right.
And I remember I had gone to Bonn in Germany back in 2007. So there the professor was very much in favor of bipolar pottery only. They had other power instruments, but all tonsillectomies were done by bipolar method and they were doing it quite well. So very good presentation and the video quality was also very good this of the surgical videos. Beautifully explained. Yeah. Thank
Yogesh, sir, thank you. Dr.
you.
Manish, sir. Thank you so much, sir. Thank you for your inputs, very important ones, and a very wonderful presentation by Dr. Anjan. As sir already said, it was very elaborate, and we checked all the boxes like importance of anatomy and yeah, we as we all know that the choice of tool can be variable. Everything has its own pros and cons. And again, wonderful presentation. Thank you, Dr. Anjan. And sir, I really appreciate the thing that you mentioned about coblation tonsillectomy. That particularly the secondary hemorrhage does occur, particularly in a strange way, from 12 to 14 days. And even I used to get a lot of post tonsillectomy hemorrhage. So now I have myself shifted towards bipolar cautery and cold steel. And so thank you, sir, so much for your inputs. There have been a few questions here.
Particularly,
Yes, sir.
particularly when the patient is from a faraway place, then there are hesitation in using coblation because
Yeah.
continuous bleeding is a problem.
Yes, sir. And they generally come at night only. They generally do not present in the morning. Generally come after 9 p.m. Better, can we take the questions?
Yes, Dr. Keshavananda, can you unmute yourself? There was a question from Dr. Keshavananda Kaur. Are you there?
Yes, ma'am.
Yeah.
I was just asking about the wand, which wand is preferable for adenodectomy? Hello?
If you are
Dr.
asking
Anjan,
me,
you there?
yeah, if you are asking me,
Dr. Anil,
the
Dr. Anil.
what one I use is the even. So I don't do precise max or I don't do
Increase your voice.
hello, can you hear me, sir?
Yes, now
Am I audible
yes.
now?
Yes,
Okay.
yes.
Okay, so for adenoidectomy or tonsillectomy also, usually I do tonsillectomy by bipolar and adenoidectomy by coblation. But if I need to do adenoid and coblation both in the younger children, then I use coblation for the both surgeries. The one I use is the EVAL,
Okay.
that is the non-aggressive one. So it has got some disadvantage. It takes little longer time, but as I am doing, yeah, I take little time, more time, but I there are less chance of injury. And if you use the precise max, if for a larger adenoid and in a patient of some 13, 14, 15 years of age, then precise max is better because those
Yes,
are
sir.
little harder here.
Yeah, I also use Precise Max for adenoid only, and preferably bipolar for tonsillectomy.
Process max is faster.
Yeah,
So
it's
for the
faster.
adenoid,
It
it
gets
is
less
better.
clogged.
And recently, I had the occasion to use the werewolf machine and wand, and
Yeah,
it is very fast. But the problem with the werewolf is that single time use, and even if, for example, your device gets switched off and you switch it on, the machine will not, again use the wand because that wand is now, it's a one single use wand. So luckily, when I was using it, after the adenoid was complete, then suddenly the machine accidentally got switched off. And when we switched it back on, then that one was not, then you cannot use it.
you cannot
So
use for the tonsil.
that is the problem with werewolf. That the adenoid one with the werewolf is like single use. You cannot use it for any other patient. Even
Right.
for the same patient, if the
It
machine
becomes so
gets
costly
accidentally
in
switched
those
off,
areas.
then it is problem.
Yeah, yeah.
There was a question from SP Phukan sir. What operation in ENT can only be done by cobbletter?
What operation can only be done by copulation?
ENT operation. Sir, Hukan sir,
It's
you have to answer.
for
No,
sir
I
only.
also do not know. That question asked to our DNB student in Calcutta.
Yeah.
But the examiner did not give any answer.
Mhm.
She told me to ask me. I don't know actually. Therefore, I am putting in the platform. If someone knows that any alternative to anything operation without
Sir,
completion cannot be
this
done.
is intracapsular tonsillectomy.
So it is thought, but we have done everything, no?
Now,
Our cases are long back, 30, 40 years back. We have done tonsil adenoma with curate and we come
no,
up
sir,
with
no, no.
vaccine.
What the question is it? What the question is it? What surgery can be done only by copulation?
Only by the completion. That is the main
Okay.
problem.
So intracapsular tonsillectomy cannot be done by any other devices. It can be done by copulation.
You want to intracapsular?
Intracapsular, yes, sir.
Intracapsular, not extracapsular, we do by
No,
dissection.
intracapsular. We have been doing extracapsular
I
since
have
long,
put
but
a question on the intracapsular, okay.
intracapsular tonsillectomy can be done by
No, you can do intracapsular also without cobbler also. That is
oh yeah.
but bleeding will be
Is it,
more.
sir? Okay, okay. Just like bulletin.
Actually,
Yeah,
with
yeah.
the coblation, you can, do the tonsillectomy, which is like a partial tonsillectomy.
Yeah, yeah.
Give you a
Intracapsular
sliver
partially.
of tonsil tissue. So, what Dr. Anjali is meaning by the intracapsular is that where a sliver of the tonsil tissue is left behind, so that the pain is less.
Yeah,
So,
yeah,
this
yeah.
kind of tonsillectomy can be done only by the coblation. Other technique, it is not possible, I think. Yeah.
Yeah, right.
Another question from Fukan sir, when to do intracapsular and when extracapsular tonsillectomy?
Intracapsular is the method of choice for tonsillectomy for everyone, but intracapsular can be done in certain situations like in a non-infected tonsils in the pediatric age group. It is if it is causing too much of obstruction, and if it is the patient's age is less than 5 or like that. So I prefer to do a intracapsular tonsillectomy in those cases. At the age of my youngest tonsillectomy is 18 months. So in those cases, I did intracapsular tonsillectomy.
There was a question from Sonali Pradhan. So, what should be the extent of adenoidectomy in patients with velopharyngeal insufficiency?
What extent of surgery can cause velopharyngeal
No,
insufficiency?
no.
Is it like
What should be the extent of adenoidectomy in patient already having
okay?
velopharyngeal insufficiency?
Okay, so I will give you the answer, then I think the experts I will give you a better comment. So for me, that if the adenoid is too big, usually adenodectomy is not the cause of velopharyngeal insufficiency. So if it is also, then it is for a temporary period only. So if I remove the very big adenoid and patient will have some insufficiency for few days and he come back. But if you injure the muscles, then definitely there may be insufficiencies. There may be because of the strictures or there may be permanent velopharyngeal insufficiency for long duration of time. So we should avoid the injury of the muscles. But complete removal of the adenoid is not going to give you velopharyngeal insufficiency
Voice is
for
very poor.
permanent period. Voice is very poor, sir.
Hmm.
You
Understand
come
voice is
close.
okay, but your
Uh,
voice is not coming.
Hmm?
I would like
Anjan, you
to
come
I would
close
like
to
to
the
add a
microphone.
point here.
Yes, sir.
So, what is the indication for the adenoidectomy if there is a patient with velopharyngeal insufficiency and he is having serous otitis media, and that is the indication for adenoidectomy? Then near around the eustachian tube and the adenoid tissue high up is not going to cause any velopharyngeal insufficiency. We can keep a tissue at the level of the soft palate and uvula, which will help to close the velopharynx. So, and that is what many times we do also when we
Yeah.
are doing the adenoidectomy. we don't, the lower end, we keep some tissue there, because that is the level at which the soft palate and uvula will approximate with the pharyngeal wall. But you can remove the tonsil the adenoid tissue high up, you can easily remove without having any problem with the velopharyngeal closure. That is what I feel we can do in such situations.
Now,
But if
can
we
I
remove
add one
that
thing?
part also, yeah.
Yeah.
If I remove the lower part of the urinoids also. So if there is velopharyngeal insufficiency or nasal regurgitation for few days, so it comes back. It comes, yeah. If the muscle is intact.
Swagata ma'am, you have a question also?
Yeah, I have a question that VPI, that means the velopharyngeal insufficiency management following adenoidectomy. You have mentioned that it comes after a few days, automatically it resolves the problem. But the patient with sometimes we get patients with cleft palate, then it is a problem for ENT surgeon to face that velopharyngeal insufficiency. In that case, we need to have surgery of the palatal repair also, along with, if possible, along with some pediatric plastic surgeon. What is your opinion regarding this?
For me, palatal reconstruction or cleft palate surgery is not done along
voice
with adenoid
improve your
surgery.
voice.
Can you come close to the
Come close to
question?
the microphone.
Just a
Your
minute, sir.
others voice is okay.
Is it okay, sir?
Yes,
Yeah,
yes.
okay.
BL now?
Yeah.
Is it okay, sir? Now?
Yes, yes.
Okay. So, palatal surgery or the cleft palate surgery is not done along with the adenoid surgery, I guess, sir.
Yes,
So,
that's
yeah.
true. But already patient have that cleft palate and following. But we have done the adenoidectomy. These type of patient actually that experience that velopharyngeal insufficient. The problem with these patients. So in
Only
that
the
case, yeah, in that case we need sometimes a second surgery we may go through for repairing the cleft palate in presence of course, in presence of a plastic surgeon. It will be always advisable to do it with
yes, yes,
a more experience with palatal cleft palate repair.
yes, yes.
I think so. I think so. What Dr. Dabulkar, what is your opinion regarding this?
Oh, sorry. Usually in cleft palate patient, we avoid doing adenoidectomy, and even if there is a velopharyngeal insufficiency, we will avoid doing adenoidectomy unless it is indicated.
Ah,
For example,
yes.
in a cleft palate patient, we have to really analyze whether it is is there any adenoid tissue which is causing the eustachian tube dysfunction, because cleft palate itself is also associated with adenoid tissue dysfunction,
Correct.
because of the abnormal orientation of the villa palatini muscle.
Yeah.
If it is because of the cleft palate, then when we are doing the cleft palate surgery, we have to do intravellar veloplasty. So
Yeah.
that will help in reorienting the muscles, and usually we avoid. But if the adenoids are too enlarged, then
Yeah.
again, first we'll do the cleft palate surgery, look for whether there is any velopharyngeal, insufficiency. Because velopharyngeal insufficiency, then the adenoid is actually helping sometimes. So unless it is causing some problem like eustachian tube obstruction, then we will be very cautious in doing the adenoid tissue clearance, which we can do near around the eustachian tube and maybe high up, but not down where it is helping the velopharynx to close. Personally, I have done sometimes pharyngoplasty also,
No.
where you can raise a flap from the posterior pharyngeal wall and bring it forward to help in the velopharyngeal closure. I remember, we had Dr. Pusarkar, sir, A.G. Pusarkar. He used to come to D.Y. Patil as emeritus professor, and from him I had learned that technique. So I have done that in a couple of patients.
No.
So it helps in the velopharyngeal closure. this
Yeah.
pharyngoplasty. Hmm.
Yeah. Thank you. Thank you. Yeah.
Thank you.
One question from
Correct.
Dr. Hemanta Mohan. He has asked importance of preservation of anterior pillar in tonsillectomy surgery.
Antibular don't use injured in tonsillectomy.
So yes, what is
Uh,
the purpose of
yes. Now,
what advantage?
Voice.
yes.
Singing.
Uh, I have done many preservation of the enteropillar. What I have seen is that once you preserve enteropillar, maybe 4 to 5 millimeter in the tonsils, and then it goes actually after the surgery, it goes inside, and healing is better. What I have seen that area. Anyhow, the formation of scab is always there. But once you place the mucous membrane that you preserve, it always gives inwards and the healing is better. What I have seen there. And that is what my feeling. I don't know what others have feeling regarding this. Maybe they can say better in that if things are there. And regarding, I want to have another question regarding that one velopharyngeal insufficiency. Adenoid tissue, yes, it is to be preserved, and according that Sir has told that first one should correct the cleft palate. Then,
Right.
if necessary, then adenoid can be removed
Right.
as far as possible. That is not harming the velopharyngeal sufficiently. But is it helpful so that without correcting the adenoid, we can put a um, ventilation tube on both sides to correct the effusion and preserving the adenoid there so that the eustachian tube function also got better. Sir.
Mhm.
Okay,
Correct.
one more question from Beauty Maibam. So, how do you manage bleeding when using microdebrider in adenoidectomy?
Okay, microdebrider usually in the muscle, if the bleeding is from the lower part, after removing the adenoid, there should be some bleeding. There definitely will be bleeding, but those bleeding usually that stops by of its own. If you wash water, saline irrigation, and all, with sometimes we can use some hot saline. So that bleeding usually stops, and if not, then we can use some coagulation, but usually it stops most of the time. But in the upper part, if there is bleeding, then we need to coagulate.
Oh,
But
say,
over the muscles, we need not coagulate. Actually, it will stop.
Okay. Anjana,
yes.
I have a question for Anjan. Up to as late as up to which date we can expect a post-operative bleeding? After that, we might say that, yeah, there is no chance of bleeding.
Till the fossa is completely covered by mucosa. So sometimes
Okay.
it is 14 days, sometimes it is 20 days. But it
Yes.
should be covered completely by mucosa. Then only you can declare the patient that yeah, you are safe now. You
Okay.
should not see a whitish color or blackish color on the fossa. You should see the complete mucosal covering of the fossa.
Okay.
Then it is clear.
Again, just for everyone, up to which day we should use antibiotics?
Antibiotics, yeah, that is a very, very good question that we should also everyone should discuss. I give for 7 days, and some people give for 15 days also. But I think that Dr. Jogesh sir will give us his
Yes,
feedback,
that
and
is
some other
very
people can
important.
give us feedback. Yeah.
I think similar answer till there is a complete cover with a mucosa, there is a chance that the infection can happen. So I give till 2 weeks, and by 2 weeks usually there is a again the epithelial layer is there and mucosal layer is there, and then there is no chance of infection. Personally, when I'm doing cold steel, 10 days antibiotic is enough, but for the population I give till 2 weeks because I have
Okay.
seen person having a secondary hemorrhage at 11 day or 12 day with the coblation Not many times it is just that they gargle and there is some blood, and I had not had to take into the OT. But yes, that occurrence has happened, and that's why I give antibiotics. When I used formulation, I'll give till 2 weeks at least.
There is one more question left. This is from admin Naboy. Probably this is Asan Mukherjee, sir, if I am not wrong. He was asking post-operative glossopharyngeal neuralgia, incidence and type of surgery. Am I correct? Can you
Yes,
unmute
yes.
yourself? You are Asan
Yeah.
Mukherjee,
You are
sir?
right. You are
Yeah.
right.
Okay.
Yes. It's very common and it's very distressing. Number one is first thing is the use of the power device. So more we use power device, the more chances of glossopharyngeal neuralgia. If you are using the cold steel, then glossopharyngeal neuralgia is little less. But if we are using powered instrument, we should use the microscope so that we don't injure the muscle layer. If you injure the muscle layer in the inferior part of the tonsil, then we can injure the lingual branch of the glossopharyngeal nerve that causes, or we can transmit some heat into the nerves that can also cause neuralgic pain later on. So we need to avoid the power towards the muscle layer. Uh, if there is any heat transmission is suspected, we'll have to use lot of saline irrigation. That way we can avoid.
Moreover, Anjan,
Yes, sir.
especially in fibrotic tonsil, where there's a lot of adhesions and all,
Yeah.
and there you are using too much of power instrument, then you may land up with this thing.
Right.
So possibility of injury that way can happen.
Right.
So our old dissection method stands good till today.
Yeah. For pain purpose.
Glossopharyngeal nerve, what is the distance from the tonsillar bed? If you do a nice extracapsular, there is no chance of injury of the extra glossopharyngeal nerve.
I am not talking of injuries, sir. It is the inflammation in the tonsil bed itself will irritate the nerve also, because transmission of heat, etc., ultimately causes irritation of the nerve also.
I don't know. I have not heard it. But
Okay,
in your elongated stellar process, some people say that glossopharyngeal neuralgia. That also some meat for reality you cannot say.
I agree. Totally agree.
Samboda.
Ah.
Yeah, or to the house also. Anybody has any experience regarding the glossopharyngeal neuralgia after surgery?
I don't have any experience. This is a myth. It is not real actually. It's a myth.
No, it is not. It is real. Many of the patients ask of complain of the pain, etc. Probably that is the same. Only the radiated pain because of the glossopharyngeal involvement.
Yeah. It's a because the lingual branch of the glossopharyngeal nerve that is very near to that area. If it is tonsil is very fibrotic and in the lower part of the tonsil, then yeah, definitely.
I don't think.
So with this we come to in conclusion.
One thing,
So before
Anjana,
yes,
Anjana rightly said the intracapsular tonsillectomy actually for OSA in a young pediatric group it is done just to relieve the otherwise it should not be
non-infected
done.
tonsils.
Chance of recurrence is more. Do you agree, Anjan?
Right, sir. That is the only indications.
That's the only indication actually.
Yeah,
It is written in the book, therefore I am
the
saying.
non-infected tonsils,
Non-infected.
hypertrophic tonsils causing the
Hypertrophic.
snoring. Yeah, causing snoring and obstructive sleep apnea. So those should be the cases. I have patients of 18 months. The patient could not even take swallow milk.
Correct.
He could not suck. So I had to do the surgery. But after 5 years, at the age of his 6, I did the second surgery.
Bulk tissue have to release.
Yeah.
Yes, it's nice that you have
But
admitted.
patient was happy for 4 years.
You have admitted,
Patient was very much happy for 4 years because I can still remember his mother was crying because he cannot take food. He was very thin at the age of 18 months.
Not gaining weight, right? Failed to gain weight.
He could not gain it.
Anjan,
Yes.
Intracapsular dissection has the beauty that even after that, 4 or 5 years also, you can have another surgery. Maybe that may be also intracapsular.
It can be done if it is not infected, but if it is infected tonsil, we should not do intercapsular. Tonsillitis, then we should avoid intercapsular.
Yeah,
If it is done only hypertrophic.
yes, maybe, but in this, see, lot of antibiotics people are used for tonsillitis. So ultimately, the infection disappears. Maybe a recurrent, but still, people used to see the tonsils as way it is increasing. So there's a still, or there's always a scope for doing the surgery.
Yeah.
So thank you everyone for your interaction. Before I conclude, I want to thank Dr. Yogesh Davolkar sir for your presence and your valuable inputs into the subject. Thank you, sir. We are also expecting your presence in our future classes as well. Thank you, sir. And
Thank you. Thank you.
I'd
Thank you
like
for
to
making
thank.
me a part of this
Yeah.
excellent academic activity.
Yeah, we are organizing in twice in a month on second and fourth Thursday. So I would like to thank Dr. Manish Singh for your presence here and your inputs as well. And finally, I would like to thank our secretary, Neboy, Dr. Anjan Jyoti Voya, for your wonderful presentation.
Thank you.
Thank you, Dr. Anjan. And finally, Dr. Biraj Das sir could join. Can you unmute yourself? Hello.
That's is there.
Yes, he could join finally, but I don't know whether he'll be able to talk or not. But
Okay.
finally, I want to conclude here, giving a thanks to everyone who has joined these classes. Thank you, everyone. With
And
this, and I
can I take
conclude.
one moment, ma'am?
Yes, yes,
One.
of
Okay.
course.
So it's a request for Yogesh sir. So in 2026 we are organizing the RhinoCon 2026
Yeah,
RhinoCon in October.
I saw it on the
So,
website. Yeah.
yes, sir. So you are
Yeah.
cordially invited.
Thank you. Thank you
We
so
need
much.
your presence here. Yeah.
Yeah.